Hello, my name is Hope Frost, and on behalf of SBK Healthcare, I'm delighted to welcome you to the recording of a practical guide to getting started with hybrid closed loop and FreeStyle Libre systems webinar. This webinar has been sponsored by Abbott. You will hear from Professor Ramzi Ajjan and Dr. Tom Crabtree during this webinar, and I do hope that you find it useful. Thank you very much and enjoy.
Thank you very much, Hope. Hello, everyone. So as you heard from Hope, I'm based in Leeds and I have an interest in technology use in diabetes. And actually, I just finished a diabetes clinic in young adults, and the majority of patients were on hybrid closed loop. So what we're going to learn today is about hybrid closed loop from Tom Crabtree, who's based in Derby, and he's a real expert in this. And what's really important about hybrid closed loops that you learn all the time. I've been doing this for quite a while, and I still go to talks and I listen to people and I learn from them. So it's really very helpful. One thing I encourage you to do is to ask as many questions or make comments in the chat. I'll be monitoring that. I'll try to answer some of the more simple questions, and the more complicated ones I will pass on to Tom, maybe because I don't know the answer to that. But without any further delays, I would like to ask Tom to start his presentation. Tom, the floor is yours.
You're just on mute, Tom.
You'd think after all these years since COVID, we'd know what we were doing with Zoom and stuff, wouldn't you? But there we go. Hopefully you can see my slides.
Yeah, we can. Thank you.
Perfect. So thank you, Ramzi, for that introduction. And yeah, the aim of today's talk is really to talk about the options that are available for people in terms of the closed loop choice that they have, and how I personally have guided a few people towards various different choices and discussions with them in clinic. Have a think about the sort of settings and the considerations that we might have when choosing settings for people. And then I've got some interesting downloads at the end from people who I've looked after in clinic to highlight some of the common problems that we see with closed loop and how we can help people move forwards. These are my disclosures. So I'm sure the audience having involvement with people with type 1 diabetes will absolutely recognize this, but my personal opinion in there is that there isn't any other medical condition that demands more on a day-to-day basis of the people living with it than type 1 diabetes. And a lot of that is because you can do the same thing, you could eat the same thing, give the same dose of insulin and get a completely different result, because there are so many factors that feed in to glucose control beyond those relatively simple things that are within the gift of the person to control. And that can include exercise, that can include the weather, but also people are going to want to travel, have a social life. There's an impact of diabetes on mental health. And for women with diabetes, impact of menstrual cycles, menopause, that we still don't fully understand on diabetes and that we need to look into more. But I think we all appreciate that type 1 diabetes really is a juggling act. But thankfully, we have got some tools to help support people to achieve glucose targets in a way that perhaps they weren't able to before. And that is hybrid closed loop. And obviously, this technology also, for lots of users, will reduce the burden of living with diabetes and improve quality of life as well, which is really positive to see. So who can access hybrid closed loop at the moment? Well, the NICE TA has made provision for people with a HbA1c of more than 58, disabling hypoglycemia, children and young people, and women planning pregnancy or in preconception phase to receive hybrid closed loop. And there are certain priority groups within that. So since the TA was launched now 2 years ago, we've been focusing mostly on children and young people and pregnancy and preconception, perhaps a handful of others who have come in with severe hypoglycemia. And now we're trying to get through the backlog as we adjust our services to meet the demand of delivering on this life-changing technology. And I think it's also important to reflect that whilst the technology is incredibly life-changing, it's not for everybody. And we're going to talk a lot about the positives today and things, but it does come with its own unique set of challenges, which can include things like feeling overloaded and overwhelmed by the data, the burden that can come with the constant alarms that some people get, the accessibility of the technology. Do they have the right smartphone? Are they able to take devices into their workplace? And that can be really challenging. So what we need to appreciate is that not every closed loop will fit every individual. And there are some individuals who won't want to use closed loop at all, and there will be other options that we can explore for those. But ultimately, we live in a world where choice is incredibly important. And I think if we can get a person to choose the closed loop and be guided towards the choice that they want, they feel then more invested in that technology because they feel like they've had more choice over the system they're using. And then this brings me on to reflect about what our role is as clinicians, because historically, I feel like pump services have been gatekeepers where we said, actually, you can have this technology, you can't. But more and more, given how broadly accessible hybrid closed loop is with the technology appraisal from NICE, we need to be guides more than gatekeepers and support people where they meet the criteria to choose closed loop and figure out which system is going to work best for them. And thankfully, we have got an awful lot of choice of systems at the moment, and this is my constantly updated, increasingly messy spider diagram of what connects with what. We obviously have the Medtronic 780G, which is within its own little ecosystem with the Medtronic Guardian sensor and the Simplera. We have Omnipod 5 available, which is compatible with the FreeStyle Libre 2 Plus sensor, but also with Dexcom G6. We know that it's compatible with Dexcom G7 technically, although the funding situation around that is perhaps more complex. We got Tandem Control IQ compatible with both Dexcom sensors, but in the United States compatible with Libre 2, and maybe something that we see on the horizon in the UK as well. And we've got CAM APS, which is using the Dana pump or the Ipso pump and compatible with the FreeStyle Libre system, FreeStyle Libre 3 sensor, sorry. But ultimately, you've got a range of different pumps there where people can have a choice of the sensor that they want to use, and the different pumps all function slightly differently. And I'll run through some of the features of each of them now. So the Medtronic 780 is a tethered pump, which you'll be aware of. It's probably the largest of the pumps that are commonly used today, compatible with the Medtronic Guardian 4 sensor or with the Simplera Sync sensor. Supply issues allowing with that one. Both of those sensors can be worn on the abdomen of the arm, so where location of sensors can be quite a big factor for people. For instance, if they don't want to have it on display on their arm, that might feed into their choices. No calibrations are required for either of those sensors. And one of the big things with the Medtronic is it doesn't necessarily require the use of a smartphone. So if you've got someone who can't afford the most up-to-date smartphone, doesn't have one that would be compatible with other systems, they only really would need to use a smartphone for cloud upload. Otherwise, they can interact with their diabetes through the pump. And the settings that are important for the 780G, we've learned are the active insulin time, which is more a function of how aggressive the system is at correcting people. So the lower the active insulin time, the better, trying to get it as close to 2 hours as possible. The carbohydrate ratio around boluses and the glucose target, which you've got a reasonably limited range of targets there between 5.5 and 6.7, with a slightly higher still temporary target, which you can set for a 24-hour period at a time. The next pump to highlight would be the Tandem pump, so the T-Slim. This is compatible with G6 or G7, but as I've already said, compatible with Libre 2 in the States. No word on if or when that will be available in the UK, but maybe something to keep an eye on. Again, technically no smartphone requirements, so all the diabetes management on a day-to-day basis can be done through the pump. Again, a consideration for people who might not be able to afford the most up-to-date smartphone, but we do now have the option to use it with T-Connect, with remote data upload into T-Source that happens automatically, and they can then also bolus through their smartphone device as well, which means that they don't have to get the pump out if they don't want to. The settings for Tandem are probably more important than for the other pumps, which do a lot more learning and machine learning than the Tandem does, which doesn't do any, in fact. But we know that basal rates are important, the weight is important, the insulin to carbohydrate ratio and the sensitivity factor are both important, and are normally recommended to be more aggressive than with other systems. And we know that the glucose target is fairly set Now, calling this a target is probably a bit disingenuous because it's more of a range, and because the algorithm is predictive, it will automatically try to correct based off what it thinks the glucose will be in 30 minutes time. So it's important to bear that in mind, that it's less fluctuating around the target, but more predicting whether you're going to be in that range and giving corrections if it thinks that it won't be. And there are also exercise and sleep settings which you can use to adjust the targets as well. CAM APS is the next algorithm and system that people use, compatible with the Dana and the Ypsomed pumps, and with two different CGM systems at the moment, the Libre 3 and the Dexcom G6. Up until, I can't remember when it happened now, but it was very much an Android-only system until the iPhone app got released, and this has been game-changing in terms of the accessibility of this system over the last 12 months, and hasn't required people who are quite wed to their iPhones to switch to Android. I know I'd be one of those people. The thought of using an Android panics me. If someone hands me one in clinic, I get a cold sweat if I'm trying to change the settings on an Android phone. But it's nice to know that people have got the option to use it probably with their pre-existing smartphone. The important settings for CAM APS are primarily the glucose target with a real broad range of targets. So you can elect to have a target as high as 11 or as low as 4.4, and you can literally have any target in 0.1 millimole per litre increments of glucose within that range. So real nuance to what you may want to use for people's targets. And weight is also incredibly important for this. So you need to make sure that that's up to date, particularly if someone's weight has changed recently, or if you're using it perhaps in pregnancy. And the final system to talk about would be the Omnipod 5. So again, compatible with, I've put two systems here. We know that it is technically compatible with the G7 that might be being used in children within the current funding framework, but isn't currently available for adults, which is where I work. But compatible with the Dexcom G6 and the FreeStyle Libre 2 Plus. Currently, no phone requirements. People do have to carry around a separate personal diabetes manager, which is essentially a defunctioned smartphone. We know that there is an app available in the United States. We hope it will be available for UK users at some point, but we don't have a feel for when that will be. And the glucose targets have a range, although they're slightly at the higher end compared to some of the other systems, between 6.1 and 8.3. So you have got a little bit of choice of target, especially if you want to run people slightly towards the higher side. And as always, for calculating boluses, carbohydrate ratio and sensitivity factor remain incredibly important for the Omnipod 5. And I guess the only other consideration for the Omnipod 5, again, within the agreed funding envelope, is that people need to ideally not be changing their pod more than every 3 days. So if you've got someone with a total daily dose above 60 units consistently, but certainly above 80, then you're probably going to need to have conversations about whether other systems might be more appropriate. So now I'd like to come on to some cases of some of the choice dilemmas that we come across in clinic. And hopefully you agree with choices, or you may have your own preferences of what you would guide them towards. The first one, a 28-year-old woman who's been on a pump for 8 years and is very soon due to have that renewed. Thinking about pregnancy in the next few years, so what option might suit her? Well, if you're thinking about pregnancy, then the only option really is to use CAM APS. Although other pumps have license for pregnancies, the evidence base seems to be strongest for CAM APS, and currently that is what is advised by national bodies. So we would be recommending CAM APS for use in pregnancy. If she was to use another system, it's important to bear in mind that there are switch funds available to provide CAM APS temporarily during pregnancy. But CAM APS is the only one with a target low enough to reach those really tight targets of pregnancy. So we really should be offering this as the preferred choice for women both planning pregnancy and during pregnancy, where that happens unexpectedly and unpredictably, as it often does for some of our patients. The next case I would like to highlight is a 24-year-old dancer who I looked after. She had a pump in the past, but it was tubed. She really didn't get on with it because it was interfering with work. Apparently, if you're doing dance to a high level or wearing tudor dress on stage, wearing a pump kind of destroys that fantasy and can make finding work difficult or can cause problems with your directors. So think about options that might suit her. And then obviously, if tethered pump's been an issue before, then probably the Omnipod is going to be the best option in this situation, both for discrete location where, amongst other things, if the tubing was getting in the way with some of the dance moves. So that's probably what we would guide her towards. And I think she did eventually start on Omnipod 5 and is getting on really well with it. I'm sure we all recognise patients who are older and the fact that lots of them can still benefit a lot from technology, but some of them really struggle with it. And the patient on screen at the moment, 75-year-old lady who's known to have severe hypoglycemia and impaired awareness of hypos, is of that generation where when she was diagnosed with diabetes, there wasn't even blood glucose testing, and she was told, as long as there's no glucose in your urine, everything's going to be fine. And there was no real recognition of the significant impact that hypoglycemia can have on quality of life. She tried a pump for a day. She left the pump stop. She went and got a chippy tea. Her blood sugars hit 11, and she went, "This isn't working for me." Took it off and went straight back to injections. So there may be conversations to have about other pump choices. Certainly, if she's willing to consider it, a pump with a lower target may perhaps help her achieve the goals that she wants, which might be quite tight control. But it's always important to remember that there's going to be people who, no matter how much we recommend it or discuss it with them, will not want closed loop. And we do have the option of connected pens. So this might be someone where we can use connected pens to try and see what's going on and use that to facilitate review of the data alongside her preferred sensor. So that may be where we direct her towards instead of a closed loop if she's not willing to reconsider it as an option. And some of the conversations we have in clinic catch you off guard. And I distinctly remember this 23-year-old woman coming in, telling me how much she enjoys death metal and gigs, and having to try and discuss how she would manage her insulin pump if she was in a mosh pit at a death metal concert. That was interesting. In terms of the choices, Omnipod maybe if she's worried about it getting pulled out in that quite vigorous, often slightly violent mosh pit scenario. But the other thing is, as long as she's using the pump the majority of the time, she's probably going to get the benefit. So it's not unreasonable to say, well, why don't you choose to go onto a pump? But if you know you've got a death metal gig planned, then where you're going to attend and want to be involved in a mosh pit or a wall of death, that you could switch to pens for the day and get yourself back onto pump safely the next day. So that is another option to think about people if that encourages them, because then they'll still be getting the benefit the majority of the time, but it allows them the flexibility to continue to enjoy the things that they do in life that perhaps having a pump, any pump, would interfere with. So worth bearing that in mind. One of the big challenges that we've had is trying to, within our individual funding envelopes, make sure that everyone who can get access to closed loop has access to it. And I know we've all been trying to think of new ways of working with large group starts, for example. The approach that we've taken locally is to refer everybody who agrees, but advise them of the long waiting times at the moment. And then when it gets to the point of starting, there's some key points that I wanted to highlight. Now, historically, within pump services, when we've had people with very high HbA1cs, either because they're missing insulin doses or not taking it, or sometimes in the context of some complications, it can be really difficult to get people's glucose levels down. We've been trying to optimize them pre-pump where possible, aiming for an average glucose of around or ideally lower than 15 as the target. And the reason for this being is one of the pieces of advice that we give constantly in clinic is if your glucose is more than 15 for 2 hours, when you're on the pump, you need to be thinking about, could this be a set failure, giving a rescue injection with a pen, checking your ketones and changing the set. But if your brain is used to seeing glucose levels of more than 15 as being normal for you, then we can say that to a blue in the face. But if someone's got a busy family life, busy work life, they're in the situation, they look, they're like, oh, it's 17, it's been 17 for 3 hours, but that's normal for me. I'll just crack on still. There's a risk there that they're going to go into DKA. So that's kind of the purpose for setting this target of 15. And what we've tried to do at Derby is have a pre-pump optimization pathway where we work with some of these individuals to get their glucose down to target, and then rather than them then join the back of the waiting list once they're there, try to then onboard them onto systems quite quickly, in the hopes that they don't have to maintain that for long. We can get them onto a pump and we can continue to then gradually optimize them. One of the other things that's I think is really important is expectation setting. And I've had a few people who've gone onto pump thinking that it's literally going to keep their blood sugars at 7 for the entire time, and that's not a realistic expectation. And lots of the pumps, because of the way they learn, so perhaps I've seen this more with Omnipod than others, but you may find that the first few weeks aren't the best whilst the pump learns about you, and then eventually things will get better. And during that time period where the patient is getting used to the pump and the pump is getting used to the patient in lots of the situations, it's important that they don't try to interfere with it as much as possible. So try not to do things like fake carbohydrates, try not to use settings like boost or ease off if they can help it, because all of those will interfere with the learning of the algorithm. And then the algorithm will almost set an expectation that they're going to maintain those behaviors in the long term to get the results that it's giving. So really need to be careful about expectation setting. The next question, and one of our big worries as clinicians, is often the impact that closed loop can have on people's eyes. We know that early worsening of diabetic retinopathy is a thing. It's a concern for us. It's a concern for patients. What I've tended to do with people with significant retinopathy, so anyone who's got M1 or R2 or higher, is have a conversation about gradually reducing their blood glucose levels, and if necessary, limiting the choice of systems and saying, look, I know you'd rather have this one, but perhaps for the first 4 years, if we put you onto CAM APS, we can set a target of 11 and then we can optimize things slowly. 4 years down the line, you'll be much closer to target, and then you can have a broader choice of pumps if you'd wish. So that's one of the things that we've sort of done locally. You can try the other pumps with perhaps softer settings. It doesn't always work because the learning they do, they're constantly trying to drive you down to a lower target, and that can be really risky. And in some of the people with really advanced eye disease, we are having clear conversations about the risk of needing further treatment. The fact that they shouldn't sit on any eye changes, any vision changes, and think I've got my appointment with my ophthalmologist in 3 weeks. There's sort of things that they probably need to go to eye casualty about. And also flagging it up to our ophthalmology colleagues to see if they can see sooner, if there are any particular big concerns, or asking their advice, particularly in the context of active eye disease where they're getting laser at the moment. And then what we do beforehand is make sure they've got all the education that to go with it. Locally, what we do is a pre-pump session, a team session, and then they've got the onboarding session during which all of these are reinforced. But I try to go through a lot of these during every clinical contact as part of follow-up anyway. Lots of this is about making sure that you've got backup kit and pens. Have they got ketone testing, appropriate backup insulin pens? If they've got insulin pens in the fridge, are they in date? Because often they just sit there. So it's important to remind them about that at every contact, and also know what to do if they do have unexplained high glucose levels, if they get ketones, and re-emphasizing that every time that they're seen in clinic. And then the two other big things that are a bit different that we need to remind people of are the treatment of hypoglycemia. So often in closed loop users, they need less treatment to bring their blood glucose up. So it's important to emphasize that, because what you don't want them to do is get onto a roller coaster where they overtreat a hypo, pump gives insulin, drops them back down. It can be quite difficult to then get things stabilized again. And exercise, and talking about either activity mode, temporary targets, whatever is relevant for the pump that they're using, but making sure they know to use that. Trying to avoid carb loading beforehand, but to drizzle in carbohydrates throughout exercise, particularly if their blood glucose is at the lower end. We also need to think about people's settings when we're starting them on pump, and local centres may do variations of this. We tend to follow the DTN guidelines, which is the 400 and 130 rules for insulin to carbohydrate and insulin sensitivity factors. We tend to keep it simple with a flat basal. We don't do any variations throughout the day because ultimately that's the backup plan for what happens if a sensor comes off and the pump has to revert back to manual mode. And we always do a 75% reduction in their current total daily dose. One of the things we've recognised is that there can be sometimes quite big variation between the weight-based total daily dose estimate and what they're actually using. And what we've done is say if there's more than 10% difference, one of the pump consultants will sign off on the correct choice, and often we go for somewhere between the two, without any real. There'll be some cases where we may go for one or the other, but usually we go halfway between the two. One of the things that will be reflected in an upcoming update to the DTM best practice guide, which you might be aware of already, is the need for probably more aggressive insulin carbohydrate ratios and more aggressive insulin sensitivity factors for Control IQ and Omnipod 5. But that will be formalized in the new DTM guidelines. And then the next thing is picking a target. And for a system like CAM-APS, you've got quite a broad choice. You may start at 11 for people who are running high and optimize them slowly. Ultimately, if we reduce people's blood sugars too quickly, we could be risking their eyesight. We could be risking autonomic neuropathy, which we do see sometimes, or other forms of neuropathy getting worse. But we might also make people feel quite rubbish with hypoglycemia symptoms, even though their blood sugars are essentially normal. So important to bring people down slowly if possible. Or if you've got someone with severe hypos, or you may want to set a normal target still. Sometimes they want lower targets, and the lower targets might stop them from interfering with the pump and doing things like fake carbs. So that's also important to bear in mind. And that is a leftover slide from historic times. There's really good resources out there, and I'd recommend that these two tools in particular. Panther Tools has a PDF document for what to review for each closed loop system, so really, really useful to facilitate review in clinic. And the guys at the DSM forum do amazing work at keeping these charts up to date, which is a mammoth task, but is an incredibly useful resource to have an at-a-glance view of what to change with each system, the advantages and disadvantages, what sensors are compatible, and they keep it very up to date and don't get enough praise for the hard work they put into it, in my opinion. And now I've got some interesting cases, which I have got time for, which is good news. So the first lady is a 58-year-old female, recently started on an Omnipod 5 with a FreeStyle Libre 2 Plus sensor, who comes for review in clinic. Now, one of the things to know about this lady, she works in a busy care home, and we're all healthcare professionals. We know what it can be like working in a healthcare environment, and this was her download. Now, to me, this fits very much with someone working in a healthcare environment because you've got clear rises with each meal, which to me means that there's either an issue with carbohydrate ratio, but the other thing to think about is bolus timing. And we talk a lot about pre-bolusing. It's probably the thing that we talk about more than anything in clinic, but it's even more important on closed loop to do this where possible. The reason being, and what we can see when we go to the next slide, is if you don't bolus on time, the pump will see your glucose rise. It will give you additional insulin to bring you down, but then you've got the insulin that the pump's given you, plus the insulin you've given yourself. You'll go up and then you'll drop down afterwards, and you'll have a hypo because you've essentially stacked insulin on top of each other. So what I tend to say to people is if you can pre-bolus, even if the carbs aren't accurate, and undercook it, that's probably better than bolusing accurate carbohydrates on time. If you know you're giving it a bit close to when you're eating, or indeed if you're giving it after eating, then you might need to reduce the amount of carbohydrates you put in, which won't stop the rise, but it will stop the hypo at the other end. So that's quite a useful thing to have in mind, and just highlights that actually one of the things that we do more than anything in pump clinic at the moment is we talk to people about behaviors around their diabetes management, and pre-bolusing is a big one that I speak to the majority of people about in clinic. The next case is a 74-year-old man, very similar to the lady we spoke about who took a pump off after a chippy tea, who was off that generation of urine testing, first diagnosed, previous severe hypoglycemia, lots and lots of incidents of this. His wife is essentially his CGM, or was before the advent of CGM, with a gold score of 7, so completely impaired hypo-awareness. Now, he'd previously been on control IQ, but he was he liked to fiddle with it, for lack of it. He just loved to fiddle with the settings, and he changed them every day, which then meant that it was really difficult to pick out what settings needed changing in clinic or if there were any patterns, because no day was working off the same settings. So initially, we ended up switching him to Omnipod 5, but he didn't like Omnipod 5 because it was running him too high at times. It wasn't bringing him down fast enough with meals, and it didn't have the option for a low enough target. So he was then doing lots of things like fake carbohydrates to try and keep his glucose down, which then led to quite a lot of hypoglycemia. So we switched him to CAM APS actually so that we could give him a lower target, and hopefully we can let the pump run him lower safely and prevent hypoglycemia without him having to do things. So for him, we set him a lower glucose target than you'd probably think for someone with this clinical picture. And his is set at 5 to try and stop him from having to do work when the pump can do it more safely than he can. And then you've got the same question around the pump target is the sensor target. And everyone's going to have this temptation to want to set him a high target because that will somehow give him warnings. But this is a man whose average glucose is 6 and who panics when his glucose hits 7. And if we're setting him an alarm at 4, he doesn't really perceive blood sugars between 3 and 4 as being an issue. So his alarm would go off, but he'd just ignore it because he's like, it's only 4. So if it was going off higher, he'd ignore it even more. And so what we want for him is for the alarms to be useful. So he's actually got a lower target set on his Libre 3 than he has than you would expect, and it's set down at 3.4, I believe. Just so that when the alarms go off, they're actually useful alarms and not alarms that he'll find annoying or alarms that he'll just ignore. But you can see that the control that he's getting on CAM APS is absolutely exceptional with 91% time in range. Some of this will be because of the work that he's putting in, but you can see that there has been a marked reduction in his hypoglycemia. It's a man who's previously sat at 10% time below range, and he's managing it with just his mealtime boluses, without fake carbs. He's using Boost a bit, he's using Ease Off a bit, but those are reasonable things to expect people to do when they're using this system. And actually, for someone who likes to fiddle, having the option of Boost or Ease Off kind of lets them fiddle in a way that's not going to cause them too many problems, because CAM APS just learns and doesn't pay too much attention to the settings. It's quite good for someone like him. The next case I'd like to share with you is a 38-year-old man. He's got really bad retinopathy, so proliferative retinopathy, previously laser treated and only just stable. He's also got gastroparesis, and the problem when you've got gastroparesis is it's really hard to get your glucose levels under control, even with the best efforts in the world, because you don't know how much you're going to eat, you don't know how much you're going to keep down, which then leads to bolus timing being off, which means you then go high and then you feel like you need to correct. And this can then lead to really difficult glycemic control. His current HbA1c was 99. What are the main considerations here? Well, for me, we need to try to get his to protect his eyes. And you'll be able to see here his Libre data from before he started closed loop, and then his data from his CAM APS afterwards. And you might look at his after data and say, well, he's not got much time in range and all that. But actually, look how much his average glucose has reduced already. And it's given him really, really tight control within that 11 target. And now we can work on reducing that slowly in a way that minimizes the risk to his eyes. I'm not going to say the risk to his eyes has gone completely, but we're certainly minimizing it by doing things this way rather than perhaps choosing other systems with lower targets where that risk could be higher. And again, another gastroparesis case. I quite like gastroparesis. I've got a lot of gastroparesis patients. They tend to come to me these days. But this case, without retinopathy, but with a very similar HbA1c, but also frequent hospital admissions. So actually, normally with hypoglycemia, but occasionally with DKA if it's in the midst of a vomiting episode. And what system would you pick? And what target would you choose for someone like this? Well, you could pick a lower target because the eyes are fine, but still you probably want to bring the glucose down slowly so you're not going to get symptoms from sort of pseudo hypoglycemia and make them feel rubbish from the off. This lady we actually did an inpatient start for, mostly because she was in hospital so much that the only way we could reliably know where she would be to start the pump was to electively admit her to hospital. She was in for a few days around that and it's worked incredibly well since. Um, and actually, this is someone who wasn't paying no attention to their diabetes. I don't think I've ever seen a Libre data quite like this, where someone is alternating quite so rapidly between very high and very low. And actually, this must make you feel dreadful. She's clearly putting an awful lot of effort in because this isn't the download of someone who's not giving any insulin. This is a download of someone who's working really hard and battling against a significant complication of their diabetes. And one of the things that I'd really like to highlight here is her time in range of 43%, because we'll see the after data in a second, but also the glucose variability. So here, her variability is 53%, and you can just see how broad that blue shaded area is in the Libre data. And if we look at how she's doing now, the reason I pointed out the time in range is actually her average glucose hasn't improved that much. But my gosh, she must be feeling so much better without this glucose variability. And although she's had a few admissions since, she's managed to reduce those significantly. She's used to be in every 2 weeks. She's been in 3 times in 4 months, which is a huge benefit to her from a quality of life perspective. And we think that improving the variability probably is what helps the gastroparesis symptoms the most. But we can now work on improving her control over the next few months by continuously reducing that target as the main thing we should be changing on this pump. It's fair to say that she probably could bolus more, but some of you may have noticed that there's quite a lot of basal going on this download. She probably could do to bolus more, but the pump is doing a lot of the work. And in gastroparesis patients, one bit of advice we might give, particularly with CAM-APS, is to use add meal and slowly absorbed meal as options so that the pump doesn't give all the insulin up front. Or perhaps to use Boost if people are really anxious. So she's got into the habit of trying to use Boost with her meals since this download, and that seems to have helped bring her down. And with that, I'm happy to take any questions.
Right, Tom. Thank you very much. As ever, I learned from you, so nothing new there. I mean, I must say, I'm not trying to be nice here, but this is a great audience because we've got some really good question coming your way, right? So I'm going to start with pregnancy. So one of the questions was, if someone is planning pregnancy, when would you plan to start them on a pump? What sort of period before pregnancy? What are your recommendations?
So we probably want them to be optimized beforehand. And my confession here is I don't do pregnancy or pregnancy planning. As a general rule, we have local categories for prioritizing patients. And if they're planning pregnancy within 6 months, then we would try to get them onto closed loop within about 3 months of that. And then their lower categories, if they're pregnancy within the next 2 years, pregnancy within the next 6 months to 2 years, just so that we can sort of decide who's going into starts. But we have a dedicated pregnancy and preconception start on a monthly basis, which we will put new pregnancies into and then fill with preconception to get it up to the numbers that we would do in a group.
Yeah, so Tom, we do exactly the same in Leeds. We have a preconception clinic, and as you say, sort of the 6 months is the period, because one of the questions was that some ladies are saying we want a 3 year before pregnancy. That's a bit excessive, but I think 6 months to a year is very reasonable. So
And what I would do in that circumstance is if they're saying 3 months before, 3 years before, I would say that's fine, we'll put you on the waiting list, but you're a lower priority. So I don't think you can say no to people if they might be planning pregnancy in 3 years, but I think you can delay them to people who are planning it sooner compared to people planning
yeah, I think that's very reasonable. The next question is about the doses of insulin post-pregnancy.
Yeah.
What happens to them?
So it instantly drops as soon as the placenta is delivered. So we normally revert to pre-pregnancy settings if we have them, then usually take a little bit off that to account for breastfeeding. Again, I'm not an antenatal consultant, so the ins and outs of what we do, of what happens probably best directed to other clinicians who do that. But generally, it's revert back to pre-pregnancy settings, but also take a little bit off that to account for breastfeeding. And normally, if people are on CAM APS, which hopefully people are during pregnancy, reminding people to use the ease off function for breastfeeding as the same way they would for exercise to stop any hypos that might happen.
Yeah, and usually there are sort of protocols in each hospital for that.
Yeah.
The other thing was that they go on CAM APS during pregnancy. What is the best pump after pregnancy? Do they continue on that, or what happens? What's the best thing to do?
So, I mean, it depends case to case. Lots of people, having used CAM APS in pregnancy, are quite happy to continue using it. Some people will want to switch back to their previous pumps. There's probably a conversation if they've had one pregnancy, are they planning another one in the next few years? Are you better to just stay on it than switching to and fro? So it's a little bit case by case basis. As a general rule, most people who've gone on to CAM APS have got on with it really well, and no one has particularly asked to switch back to other systems other than perhaps people who Omnipod users wanting to get back to a tubeless pump.
Yeah.
But
I mean,
we've just dealt with it case by case.
that's exactly our experience. And of course, you have to respect what the patient wants to do. Right. So that's the pregnancy question. So moving on, a practical question about Omnipod. So if you, for instance, run out for whatever reason of G6, right? Can you switch to G7 and then back to G6 later?
So you can, because the pods have changed recently, and some of you'll hopefully have noticed that there are now Libre pods and there are Dexcom pods. So they have to have the right pod to go with the right sensor. So that's important to highlight. So they can't just switch between Libre and Dexcom the way they would have done before. You can of course give them G7 to tide them over if they're waiting for G6 delivery, but it's important to remember that the G7 currently is not funded within the adult population. It's above the nice cost effectiveness threshold. There's work going on nationally to see if that can be rectified. There's been an agreement made for children, so anyone up to 19, I think, if they're within children's services, can use G7. We're not clear on if they can continue G7. That's again a separate conversation. But there's no reason why they couldn't switch between G6 and G7. They just need to have the app on their phone to activate the sensor.
So the next thing, Tom, is the recent safety alert with the Libre 3 and Libre 3 Plus. So the question mark was around, do we have any sort of shortcomings in the system that we should have different ways to deal with safety when it comes to these issues? If there are accuracy problems with the sensors, what should we do? And have we got enough safety measures in place as it is?
So what I would encourage everybody to do, and we try to do this as part of our starts, is give people the information for MHRA yellow card alerts, because although we can submit them as clinicians, patients can also submit sensor errors or concerns directly via that. The Libre 3 issue is obviously something that's happened this week, and I would encourage people to speak to their local Abbott representatives about that. And there may be a link we can pop in the chat for where patients can check whether their sensors are affected or not. But please do speak to your local Abbott reps. But if you're finding that there are patterns, then one of our duties as clinicians, but also open to patients, is to report things to MHRA so that these things can be picked up. And if there is an issue with a specific batch, then that can be cascaded and people can stop using those sensors. So that would be
I would like to comment that, of course, with any technology, you can have issues, and the important thing is to have a constant quality control studies going on, which we know with the big sensors that does happen, which gives you some sort of a safety net. But of course, as you said, Tom, we've got to be vigilant because things can go wrong. This is real life. Okay, so there was a question that is actually quite close to my heart. Tom, see what you think, is about people requiring high doses of insulin. So the first question is about which pump would be the best in these guys who've got high doses, but there's sort of a number of questions coming your way on that.
So we tend not to do Omnipod for the reason of the more frequent pod changes. Now, any of the other pumps will cope with higher doses of insulin. I think there is technically an upper limit on the tandem, the value for which is escaping my brain at the moment. But all of the other systems, because the reservoirs are lower cost, you can kind of get away with more frequent changes, even if someone's on 300 units of insulin a day. Obviously, some of you will know that the IPSO reservoirs or the pump carts, when they're available, are only 160 units. But there's been some interesting stuff put out by IPSO recently about being able to reuse their reservoirs. So as long as the patient changes the reservoir, disconnects the cannula, primes, and then reconnects it, they don't even need to recite the cannula until the 3 days are up. So that's quite nice to have as an option. But it's all when you get to very high doses of insulin, when you're getting up to 200 or 300 units a day, I think all the systems start to struggle a little bit at that point because you're at the extreme of what they're.
Yeah, and I'm glad that you pointed that out with the Ipsomed, that despite the fact that it's a small reservoir, you can change it without changing the set. But so the next question was about, some people combine long-acting insulin with the pump. What are your views on that?
So we don't do it locally. We've not really got an evidence base to support the safe use of doing that, and ultimately, we need to be doing this safely. What we don't want is people to then have severe hypos on an Omnipod and then you've given them an unlicensed therapy, because actually the problem with giving them a background insulin on top of their particularly Omnipod, because that's where you're most restricted in total daily dose, is that the pod can't subtract that insulin. If you're going low, you've still got your transceiver on board. It's going to really struggle to prevent hypos for some people in that circumstance. So at the moment, we've not done it. It might be work that happens in the future to explore in more detail to see if it is a viable option. But at the moment, certainly in Derby, we've not been doing that.
Yeah. So yeah, I am not keen at all on that. We've done it in a patient who had repeated DK admissions, but that was a different story.
Yeah, that might be a different circumstance.
Yeah.
To maintain safety around set failures, but certainly we wouldn't do it just to reduce the total daily dose and facilitate a pod essentially, because that's what you're asking, isn't it?
Yeah. So staying on the high doses and of insulin, this is the last question on this subject, is what are your views on adjunctive therapies to insulin?
So we kind of try to play it by the book as much as possible in Derby. So at the moment, we would consider metformin for what it's worth. I don't feel strongly that it's going to make any difference, but we have done it for some people, and particularly if in women who may have features of PCOS as well, you can get away with it in that circumstance. We obviously had that peri-COVID fever dream where dapagliflozin was licensed for type 1 diabetes, which it now isn't. But we don't use SGLT2s in type 1s at the moment. And then the big question is going to be GLP-1s. And again, we've held off using them in our type 1 diabetes population, mostly because it's not going to be funded or picked up by our ICB. We also don't fully understand how we need to change the settings to maintain safety, because there's a risk that we cut back the insulin too much, they end up in DKA, or we don't cut it back enough and they end up hypo. My gut feeling is that within the next 5 years, we probably will be using GLP-1 more in people with type 1 diabetes, but at the moment it's not licensed and not something that we're using. I was going to say routinely, but I don't think we've got anyone with type 1.
Yes, so
and a few private funders who've gone and seen someone else.
Yeah, so we've been a little bit more aggressive than you, Tom. So in terms of metformin, our experience is that around a third of patients actually respond, but long term is not great, and that's what the studies suggest as well. We've written a recent review on that was published this year, and definitely it doesn't last. In terms of the SGLT2 inhibitors, we still use them actually in Leeds, but it has to be through only 2 people. It has to go through 2 particular consultants for that. Because as you know, the reason they removed the license wasn't sort of safety, but other reasons. And you'll be interested to know that we are also using GLP-1 in very selected patients on a case-by-case basis, very high BMI that is increasing very rapidly.
Yeah.
And I just passed it through the DNT committee last week. So I'm going to have now negotiations with the ICB for more use. So we'll see how that goes. But I agree with you that this is because the problem we've got that once people develop this sort of double diabetes, if you like, and a type 1 and a type 2 phenotype on top, their risk of problems increases quite a lot. And I do appreciate that those drugs are not without side effects, and we've got to be mindful of that as well. But it's always an issue of risk and benefit. So we'll see how it goes.
And I hope in the future, particularly with SGLT2s, we could be more encouraged about safety if we had access to continuous ketone monitoring, which we know is an active area of research. So that would probably markedly
Precisely.
improve the safety of those.
Yeah, I'm glad that you raised that actually, Tom. Okay, so the next one was a really good question about why high risk of DKA on pump start in people who've got a high A1C. Why do you classify those as high DKA risk?
So one of the things that we know about pump therapy is well, historically, it has increased the risk of DKA in people. And that's because you've obviously not got any background insulin. If the pump disconnects and you don't respond appropriately, you're not paying attention to your blood glucose levels enough, then you could end up developing ketones within 2 hours of that happening. But certainly within 4 to 6 hours, that's going to be getting you into real sticky situations. Now, historically on pump, before they were closed loop, even with high glucose levels, the pump would still be, some people would run high and they wouldn't get ketones, but because the pump's only doing what you're telling it to, and it shouldn't be responding to the high glucose levels automatically. But with a closed loop, any closed loop system should be trying to correct you downwards to lower than 15. And so the general advice and the advice from the Diabetes Technology Network is if you're more than 15 for 2 hours, you need to change your cannula. Now, if you come at that from a high HbA1c, as I've said already, we can say it to a blue in the face, but if you're at work, you're busy, you're running around after the kids, whatever else, and you look at your phone and you're like, oh, I've been 17 for 2 hours, but I'm used to being at 17, it's not a problem for me. And then you put your phone away, don't respond to it appropriately. In 2 hours, if that was a set failure in 2 hours' time, then you're going to be quite poorly. And so that's why we try to get people down a bit to start with, just that they are used to seeing lower blood sugar levels. Now, there are some people who, despite our best efforts, don't manage that, and we will probably still put them onto pump, but we just give them lots of additional support and follow up around that. But we just need to be wary that there is a risk of DKA in those going onto it with higher HbA1cs if we're not emphasizing the right points.
So that's one of the issues with the pump, that the risk of DKA is higher for obvious reasons. So one question was about the HCL systems. Do they all have an exercise setting?
So they're called different things on each system, but all of them will have some setting that will accommodate exercise. So on Omnipod 5, it's activity mode. On Tandem, it's exercise mode. On Medtronic, it's a temp target, so it will increase the target higher. And on Ipso and Dana, within CAM-APS, it's ease off. And to get the most out of exercise mode, people need to be aware that they need to try and use it at least an hour before, but preferably a little bit longer than that to let the insulin peter out their system a bit, use it for the duration of exercise, and then probably for a period of time afterwards to prevent any hypos that might occur after exercise.
I must say, Tom, this is the nicest way anybody explained the different exercise modes on the pumps that I heard so far. This is brilliant. Okay. What about delayed bolus? Because that happens quite a bit. What do you do with that?
So there's specific percentages that I always have to look up a little bit, but essentially, if you're bolusing up to half an hour before, you probably need to take about 25% to a half off the carbohydrate ratio. Sorry, up to half an hour after. Half an hour to an hour afterwards, then you could probably get away with giving about a quarter to a half. A little bit of trial and error per patient of what to do. But if you're more than an hour afterwards and you realize that you've not bolused, then the best thing to do is to just give whatever correction dose the system recommends. So go in, put in 0 carbs, and then just give whatever user-initiated correction that it suggests. The other option for for one of the systems, so for CAM APS, is you may want to use Boost as the alternative, which will bring you down more quickly but safely without giving you a load of insulin up front.
So again, very, very clear-cut recommendations that actually does work. I mean, that's more or less what we do
And I think setting the
ourselves.
expectation around that is that the reason we're doing that is going to have no impact on them going up, but it is going to prevent the postprandial hypos that some people really struggle with.
Yeah. So the next question, that if people who do not, for people who do not carb count, is there a particular system that you prefer?
So there isn't really, although each system has different options. What we do sometimes do is give people advice, uh, probably with some dietitian input to figure out what their average meals look like over a few days. Of this is, 20 grams of carb for a small meal, 40 for a medium-sized meal, 60 for a big meal, and do it that way. Some of the systems, particularly CAM APS, has the option of programming fork sizes. So if they can't carb count, they can just select a fork size depending on how big or small their meal is. And that's quite useful. And I think one of the things that I've really learned working with closed loop is that accuracy of carb counting probably doesn't matter anywhere near as much as it used to. The main thing is the timing. I would much rather someone put in slightly incorrect carbs 20 minutes before they eat than put in perfect carbs a minute before they start eating, because the system is going to work much better that way. So we need to be talking more probably about carb awareness rather than accurate carb counting. And naturally, that facilitates closed loop for a lot of people, because one of the barriers to pump was you're not really carb counting properly. Whilst actually a closed loop, you just need to be aware. And if you can't even be carb aware, then we can use fork sizes or just give you some really simple advice to follow that will hopefully get you to make the most of it.
So there's an interesting question here, Tom, is that how do HCL systems differentiate between real hypo and compression hypo?
So the answer is they don't. They can't tell the difference. It works off the glucose data that it's given. Um, Compression hypos, it'll obviously bounce back up to normal. They're usually relatively short in duration with a sharp downward uh, swing, but it's one of the limitations of the technology is it's not going to know that whether it's compression or genuine. And maybe in future as technology develops, we'll end up getting sensors that are less affected by compressions or algorithms that can detect it. But at the moment, that is a limitation.
And this question is coming from me, Tom. I see a lot less compression hypos than I used to. Is that your experience as well?
I think so as well. And I think there's an awful lot of perhaps what we used to think were compression hypos that perhaps weren't. To me, a compression hypo is a very short, sharp down, and then it might be down for half an hour to an hour, but then it usually just pops back up afterwards. But the sometimes what you see is which is the long lows overnight are probably more related to insulin regimes, because the reality is most people, even if they lie on their sensor, are moving enough during sleep that I wouldn't expect it to stay low for sort of more than a couple of hours if it was a compression, I don't think.
And an important question here, Tom, about use of pump in blind people or people who have
Yeah.
got sight impairment.
It's really tricky, and we've tried our best with some people, but it's a challenge that we need to put out to the companies and to industry to say they need to do more to facilitate pumping people who are visually impaired, which is a not insignificant number of our population. Our main requirements are that people can see enough to be able to independently do set changes. Some systems might be better than others. So, for instance, with CAM APS, because you've got an app, you could probably use the accessibility functions within your smartphone to read a lot of the things on screen. So that might be helpful. Perhaps having the reservoirs is easier in some ways because someone could pre-fill the reservoirs and put them in the fridge for you. With CAM APS,
Yeah.
maybe that makes it easier. But there is always going to be a higher risk there. And if you had someone who had impaired vision, then one of the bits of advice is, if you're running high, you're going to just need to disconnect it all and give a pen injection. And ultimately, the challenge is out there to industry.
Yeah.
Give us pumps that we can use in visually impaired people.
Thank you very much, Tom. I mean, this has been really great. We had some great discussions. Unfortunately, we're on time now. It's 2 o'clock. So thank you very much for the great questions, everyone. Remember, the adjunctive therapy is not licensed. You've got to be careful about that. So it's not that I'm recommending it. What I'm saying is what we use in these and for very selected cases. And back to Hope.
Brilliant. Thank you so much, Tom and Ramsey. That was a really brilliant workshop webinar. So I hope that you all found it useful as well. And I hope to see you all again soon. Bye.